Hello, I'm Dr. Martin McNamara, and we've had recent changes recommended at our hospital. I'd like to bring you up to date on what's happening in the local area with regards to our services and present for you the slides that were presented on April 7th presentation at the Community Centre in Penetanguishene. And so for those of you who are not familiar with Georgian Bay General Hospital, a recent consultant was hired to do an efficiency review at our hospital, and the result was 108 recommendations, 14 of which were clinical. These clinical recommendations have us as physicians very concerned about the fate and about the future of our hospital. And I'd like to go through with my slide presentation what exactly these changes will mean to you as patients and you as customers coming to our hospital. So for today, we're going to present the current situation locally, provincially, talk a little bit about who the participants are and how you can get involved, why the physicians got involved, and how you can help. So we all know that Parliament and the Canada Health Act recognizes that continued access to quality healthcare without financial or other barriers is critical to maintaining and improving the health and well-being of Canadians. The primary objective of the Canada Health Act is to protect, promote, restore the physical and mental well-being of residents of Canada, and to facilitate reasonable access to health services without financial or other barriers. Many of the recommendations put forth will present significant financial barriers to a large percentage of our population living in North Simcoe. The Ministry of Health for 2016 has announced that they will increase public health and hospital funding by 0.33%. Our current rate of inflation is 1.5%, 1.8% last year, projected to be 2% in 2017. We know that the cost increase in wages governed by the Ministry of Health and the Ontario Nurses Association and other associations generally increases by 1 to 2% per year. So it's clear to anyone with a pen and paper that the amount of money being put out in wages, benefits, and support services far exceeds what the ministry is willing to budget for us. Midland Hospital over the last 10 years has had 5 efficiency reviews, each of them making suggestions on how to save money. So far, the hospital has contracted out to the lowest bidder, food services, security, maintenance, house cleaning, and laundry services. So we reached a point at our hospital where the only place left to cut are critical and core services. In terms of public health funding, we know that our own source revenue for Ontario was 14.4% of the GDP, meaning that we spend 14.4% of our budget goes to healthcare, as opposed to other provinces which run about 3.5% higher. So we do know that there's still some room in the government's budget to fund hospitals at a much better rate than they're doing now. The cutbacks have been very difficult for the hospitals to take. We know that Stats Canada indicates that Ontario has the lowest revenue as a percentage of economy of all the provinces. We also have the lowest number of beds per 1,000 people, and I believe that number is somewhere around 2.8 beds per 1,000, as opposed to provinces like Newfoundland, who average about 4 beds per 1,000 people. Excuse me. Out of all the developed countries viewed worldwide, only Mexico and Chile have fewer hospital beds per person than Ontario. Strangely, at a time when austerity is being practiced and preached by our government, they have cut doctors' wages by 6.95% over the last 2 years. They've held hospital budgets to 0% increase for 4 years. The LHIN and other governing bodies have averaged an 8 to 8.3% increase in their wages and costs. And so we really have to ask, if austerity is being practiced, why is it not being practiced at the very top? We know that the LHIN over the last 3 years has increased their meeting expenses by 8.3%, their governance costs by 3.3%, and their per diem costs, so meeting costs per day, by 8.9%. Their wages and salaries have increased by 5.35%. So 2 issues are clear from this data. Shouldn't our healthcare administration lead by example? And secondly, if we're all practicing austerity, it should come from the top. On our current state of affairs, we know that GBGH is currently in red. We have approximately $10 million in long-term debt that we're servicing every year. And we also have approximately 1.5 million shortfall in operating costs yearly. So we're actually putting out 1.5% more money than the ministry gives us just to cover our current operating expenses. We're barely meeting the long-term debt's financial costs in terms of interest. And the LHIN and the ministry are our only sources of support. So we can't farm out services, we can't go private. We can't take money from current donors to meet operating expenses. We're only allowed to use those dollars for capital costs such as beds or even some of the supply costs. In response to our request for assistance, the LHIN arranged with our hospital to put together a financial review by a company called Geyer and Associates. Their 14 clinical recommendations were viewed by physicians as being badly flawed for a number of reasons. First of all, there was no consultation with our most at-risk populations, First Nations, our Francophones, our Métis, and people who are marginalized and street people. There was absolutely no discussion with them as to what the effects would be on them. Physician leaders of each of the services, so for instance, the chief of obstetrics, were not asked or consulted on what the impact would be to their services. The statistical analyses were flawed. Some of the metrics and data that they used were not standardized to things that we normally count for. Our hospital counts patient comfort, patient quality, patient satisfaction as being a metric. These weren't even looked at. What they actually looked at were bizarre concepts such as sentinel events. So in obstetrics, a sentinel event refers to an event that could potentially lead to litigation. So for instance, if it's a difficult delivery and forceps are used, that could potentially lead to litigation. On the basis of that, they calculated that our risk was twice that of the provincial average and used that as a means for discrediting our program. In actual fact, our program has 4 practitioners in obstetrics whose combined years of service total almost 130 years of service, and in that time we've only had 3 lawsuits. So there's a large gap between what actually happens and what potentially could happen. There was no consideration of outside factors such as distances traveled. One of our most important clients are members from Beausoleil First Nations who travel half an hour on a good day by ferry and another half hour by land to reach our hospital. So somebody who is pregnant or is having a crisis requiring ICU has to travel by EMS for 1 hour on a good day before reaching our hospital. Imagine arriving at our doors only to be told that they have another hour drive to Orillia or Barrie to deliver their child. It's most likely that there'll be deliveries on the side of the road. Our chairman of the board in January 21st stated that the recommendations were voted on and accepted, and they were looking for members of the community to assist in implementing them. Because of the huge outcry from you, the consumers, the patients, the board has since decided that they take those 14 recommendations in-house and look at them through in-house committees. That doesn't reassure us as physicians, because if the financial constraints have not changed, it's unlikely that the conclusions reached by these committees will change. So if you're given a budget for bologna sandwiches, you're not buying steak. It's pretty clear. The LHIN has yet to vote on or approve these recommendations, and the Ministry of Health has stated that the recommendations are just recommendations and considerations. However, it's clear from us working at the grassroots level that that's not so. And there have been some changes over the last few weeks that I will share with you in a separate video. So for the moment, it's really important for you as our patients to remember that GBGH, the physicians and the nurses, are carrying on business as usual. We're still doing deliveries. We're still available as services. Nothing's been cut back as yet. And so I would encourage you to continue to use our services. If we and the ministry see a drop in the use of our services, that simply gives them another reason to cut back on our programs. And so at the moment, we're continuing on business as usual. We'd love to see you at our hospital, and we're going to continue to provide the services as best we can. So our committees, the in-house committees consist of 3. There's a surgical committee, an obstetrical committee, and an ICU committee. They're tasked with looking at alternatives and providing recommendations to the board. So their choices, I believe, are 3. They can either find an alternative solution while staying within the same budget. They can recommend instituting the cuts as supported by the Geyer report, or somehow find a compromise. It's our feeling as physicians that given the same budgetary constraints, it's unlikely that another option will be found. I think that you as members of the committee should be monitoring these members of the community should be monitoring these committees very carefully, because there's going to be certainly a lot of pressure from our administration to proceed with the recommendations as put forth by the Geyer report, and this is, we believe, a movement that would be catastrophic to our hospital and to our community. Who's working with us at the moment? We have the Mayor's Committee on Healthcare Services. However, their mandate is to look at not only the hospital but healthcare for the entire area, including transportation and finances. The mayors themselves are working very hard with the ministry, looking to find a funding alternative that will better guarantee constant services at our hospital. The current funding formula is badly flawed for our hospital size. Excuse me. The ministry funds us 30% base formula, which means that no matter what we do, we get 30% of that money. And the other 70% is based on the number of patients we see, the type of illnesses they have, and a host of other factors that are clearly too complex for most of us to understand. We've had several physicians sitting in on these sessions, and we come away scratching our heads, wondering at some of the methods that they've used to calculate out these funding formulas. We have our MPP Patrick Brown working with us. We have a group of citizens through the Save Our Services Committee in Facebook. We have a number of organizations in the community, such as Bosley First Nations. We have the FOTSA group from Tiny. We have a number of concerned citizens. We have the Rosewood group who's assisting us with petitions. So all in all, we're all moving ahead, I think, with one common goal. Why are we concerned? Well, the number one cut that comes out of these recommendations is that there would be no obstetrical care or no gynecological care. 52% of our population in Tiny are female. That means that every one of you will have to drive another 35 to 40 miles for the most basic services, everything from tubal ligations to IUD insertions to pessaries to assistance with things like bladder incontinence. Marginalized women in particular will be affected because they have absolutely no way and no means of getting to these services. The second recommendation is that there would be no local pediatric surgery. Our pediatric surgical program is not a large program, but it does service a very, very important group of people in our population. The pediatric surgery program is headed by a consultant, an ear, nose, and throat specialist from Barrie, who travels here on his own cognizance weekly to see patients. Last year, he performed 22 tonsillectomies and 18 myringotomy tubes for ear problems for children. The consultants suggest that we can send these patients, the Guard and Associates consultants suggest that we can send these patients to Barrie or Orillia for care, but in actual fact, the truth is that none of these families have cars or means of getting there. And so having the consultant come to Midland is a viable alternative. The Ministry of Health, the LIN, and their consultants would have us stop this program altogether. The same goes for dental care. They've suggested reducing our dental care at the hospital by half. Again, the people serviced by this are people who have no other alternative for care. We would still have to send them to Barrie or Orillia, so the cost would be the same, other than the added financial burden of traveling. The other concern we have as physicians is that if you're having procedures done in other hospitals, we have no access to your records. Typically, patients who have surgery done in Barrie are told to report to the nearest emerge if they have complications. If you come to our emerge in Midland, we don't have any records of your procedure. We have no way of reaching your consultant since they're off duty at night. And we call our own consultants, who then are faced with the task of trying to figure out what went wrong with the procedure that they didn't do. So we have some very large and worrisome concerns about that. Implementing these recommendations will also impact recruitment of our physicians. We have 2 physicians who have come to this area looking to not only do family practice, but also obstetrical care. Both of them have said they'd leave. Our emergency physicians, as a group, are not interested in practicing obstetrical care in the emerge, and actually 3 of them have actually said that they would leave. We're not qualified to do deliveries in our emerge, and nor are we qualified to assess to see if women are in labor prior to making a trip to Orillia or Barrie. I think that it would increase the risk tremendously, and there's the only upside is a savings of a few $1,000s for the hospital. I think that the recommendations would also see us lose student doctors, nurses, nurse practitioner students, nursing students, and a number of other resources that we use and depend on constantly. Implementing these resources or these recommendations would also mean that we would have trouble keeping consultants after hours. So most doctors won't do after hours on-call work unless they also have work to do during the day. And so if these services go elsewhere, those physicians will follow. There'll be an increased burden on transport services. The consultants who provided these recommendations failed to realize that in all of Simcoe County, there are only 2 ambulances assigned to inter-hospital transfers per day. Simply doing the math would suggest that if I have one patient come in with a heart attack who needs to go to South Lake and a second patient come in with an imminent delivery, I've just exhausted the entire resources for Simcoe County. We would have increased costs in transferring physicians. If you come to Midland for your delivery or are transferred to Orillia for delivery, the costs are essentially the same in the hospital. The only difference is that now we had an added cost of a physician accompanying you in the ambulance. We have the added cost of EMS and nursing. And so I'm at a loss to understand how shifting these services to another hospital will benefit the ministry, save money, or benefit you, the patient. The recommendations would suggest that 18.5 nursing jobs would be lost at our hospital. We would lose 7 more acute care beds, and we would probably lose the services of a local physician who assists with pregnancy terminations. Given that the financial support has not changed from the ministry or from the LHIN, it's unlikely that without your support that we're going to get anywhere in pushing for these changes. What are the benefits of these cuts? Well, the consultants would have us believe that implementing these 108 recommendations will result in a $5.2 million savings per year, so that in 2 years our budget will be balanced, but at the cost of services. We know from projected forecasts that using the ministry's financial formula that by the 3rd year we would be in the hole by 1.3 million again. And so, as I've said before, this is like owning a 200-acre farm and selling 50 acres to pay the taxes, and then the following year selling 50 more acres. And within 4 years, you've basically left with a house and a barn. You won't be able to provide services, and that's what will happen here at Midland. What can you do to help? Well, one of the biggest things you can do is be involved. You can join our hospital community advisory group. You can phone the hospital and join these in-house committees, because we do need representation from the participants, particularly from our patients. You can write and call your MPP, the Minister of Health, and the LHIN to make your needs clear and let them know that Midland does deserve and need a viable hospital. Certainly, you must support your mayors in their work developing an alternative funding arrangement. Jerry Marshall, Scott Warnock, our mayor from Tiny, from Bosley First Nations are all working very hard to try and change this with the ministry. Consider being part of future community actions. You may consider organizing a group to come to our hospital meetings. Our board meetings are the 3rd Thursday of every month. And form a little group outside to let the board members know exactly what it is that you want as community members. You can consider writing to Mr. Patrick Brown and showing him your support for his work and trying to get reasonable funding for our hospital. And you can follow the cuts and administrative activities at the Ontario Health Coalition website, as well as the SOS Facebook website. We have a day of action planned on the 23rd, which is being put together by Concerned Doctors of Ontario. And we've just completed a day of action from local citizens down at Queen's Park, which took place on the 20th. And so for those of you who haven't been involved yet, please do so. We need you to save our hospital. Thank you.